Bismillahirrahmanirrahim. Welcome to the last lecture of palpation for physical therapists. Today we will be discussing how to palpate leg and foot, and we will start with the topographical views. If you look at the leg and the foot, topographically we see a few structures. These include on the front the patella, which is the largest sesamoid bone in the body, the tibial tuberosity, the pes anserinus, which is an attachment site to the soft tissues, Tibialis Anterior, shaft of the tibia over here, the medial and the lateral malleolus, the tendon of the Tibialis Anterior being most prominent on the front, and it is in alignment with the big toe, and the extensor digitorum longus tendons. These are the structures that are very obvious in the front view, while in the posterior view we can look for the popliteal fossa. This is the space which is just posterior to the knee joint, and there is a very small muscle called as Popliteus, which is considered to be the locksmith of the knee joint because it helps unlocking the knee. Similarly, the gastrocnemius, the belly of the gastrocnemius muscle can be seen, and the calcaneal tendon or the tendon and Achilles can be seen, the lateral malleolus, and the heel. This is a closer view of the foot from the front, which is also called as the dorsal view, and this is the plantar view. In the dorsal view, we can see the tendon of the tibialis anterior being the most prominent, and it is the thickest tendon. Then we can see the four tendons of extensor digitorum longus muscle, and the tendon of extensor hallucis longus can also be seen. So this is the tendon which is supplying or which is connecting with the big toe. On the plantar view, we can see the metatarsals, the arches, and the calcaneus making the heel. You need to explore the skin and fascia in this region, and you will see that the fascia is and the skin is mobile in mediolateral direction, while it is less mobile or firmer in the craniocaudal direction. Over here, you can also see the skin over the foot being thin and mobile. This is a very similar experience for the physical therapists as it happens with the quadricep tendons, as it happens with the hamstring tendons. The hamstring tendons, they become more accessible and they become more prominent when the knee is flexed. So similarly, when the foot is plantar flexed, this tendon is very accessible and it is very easily graspable. But when you dorsiflex the foot, then this becomes more difficult to palpate. The bones of the knee, leg and foot, there are two bones that make the leg, the tibia, which is the largest bone as compared to the fibula, and the fibula is a small bone as compared to tibia. The fibula makes the lateral malleolus, while the tibia makes medial malleolus on the lateral surface or on the distal end. Then you can see there is anterior tibial tuberosity on the patella, which acts as a site of attachment for the quadricep tendon, and the superior or the proximal tibiofibular joint and inferior or distal tibiofibular joint. There is a membrane in between these two bones. Then we have a few bones that make the foot. The foot is divided into hind foot, mid foot, and forefoot. So the calcaneus, the talus, There is the joint, the ankle joint is formed between the talus and the tibia. So it is called the tibio-talar joint. Then talocalcaneal joint, and similarly the cuboid, the navicular, and the cuneiforms. There are three cuneiform bones. Then we have five metatarsals, and we have 14 phalanges. This is another closer view of the bones from the front and from the back, the tibia and the fibula. So the most prominent part is the anterior tibial tuberosity. Then this is called the tibial plateau, or the surface that receives the femoral condyles, and this is called the tibial plateau. This is the medial condyle and this is the lateral condyle of the tibia. This is further deepened by the presence of meniscus, and they improve congruity in the knee joint, the shaft of the tibia and the fibula, and the distal part of the tibia and fibula, making the medial and lateral malleolus. In the posterior view, we can see almost the same structures like the shaft, but there is also a soleus line which is present more medially, and there is a groove for insertion of semi-membranosus tendon. Similarly, there is also a groove for tibialis posterior and flexor digitorum longus tendons that inserts on the distal part on the posterior surface of the tibia. This is a closer view or a magnified view of the patella. The patella is also an inverted triangle shaped bone because its apex is directed towards the foot and its base is towards the pelvis or the superior surface. Then this is the underside view or the posterior view of the patella, and you can see it has two facets, the lateral facet and the medial facet, and the apex can be seen also. So these surfaces, they come into contact with the femoral condyles, and there is a very thick articular cartilage. In the knee region, the articular cartilage can be as thick as 6 to 8 millimeters. So this is a lot of thickness for the cartilage, and this is the reason that it can resist a lot of forces. Here you can see the knee joint, a closer view of the knee joint. All these structures, the patella, the medial condyle, the lateral condyle, and even the epicondyles, they can be palpable very easily because this region is very thin. The skin in this region is very thin, and the bones, they are very broad and they become very superficial in this region. The tibial tuberosity is also very prominent landmark in the anterior knee. You can also look for the eyes of the joint. The space between the femoral condyle and the tibial plateau is referred to as the eyes of the joint. Here you can see again the lateral condyle, and we all know that the medial condyle is a lot broader and larger as compared to the lateral condyle because this condyle receives more weight and this is more prone to develop degeneration as well. Then the patella itself, it glides in craniocaudal direction in the intercondylar groove or the groove for the patella. And there is a very important clinical condition called as the chondromalacia patella, or recent name is patellofemoral pain syndrome. So this is a condition in which there is softening of the patella and there is rubbing of the patella against the femoral condyles and there is maltracking of the patella. So the patella, instead of moving craniocaudal direction, it tends to move in supralateral direction, and this is due to the imbalance between the vastus medialis, which most commonly becomes weak, and vastus lateralis, which becomes tight and strong. When the knee is in flexed position, the tibia can rotate medially and laterally. So this medial and lateral rotation of the knee is only possible when the knee is flexed. There is also an important structure that passes around the neck of the fibula, and that is the common peroneal nerve. So injury to this site or the fracture of the head of the fibula in the proximal region can lead to the disturbance in function of the common peroneal nerve. Now this leads to a condition which is very important clinically called as the dropped foot. The patient is unable to uh, dorsiflex the foot, and hence the condition is called the drop foot, and it is a very important clinical condition because of the close proximity of the common peroneal nerve with the fibular head. The bony landmark trail of the knee is very simple. You need to locate and palpate the patella, which is very obvious. There are a lot of bursas that are around and above and below the patella. So suprapatellar bursa, infrapatellar bursa, prepatellar bursa. So these are the bursas that are present, and the bursas are fluid-filled sacs that help to reduce the friction. The tibial tuberosity, sometimes referred to as the anterior tibial tuberosity, it is the most prominent part on just below the knee joint, and it is the site of attachment for the quadricep tendon. Shaft of the tibia, which is continuous below, and it is also very prominent, and the head of the fibula, it is accessible laterally, and it is just below the knee joint, because these surfaces are making the knee joint. And it is important to remember that the fibula has little or no contribution in weight bearing, and it does not contribute in the knee joint, and it is outside the cavity of the knee joint. The second bony landmark is called the Weddell walk. You need to find out the patella in the midline, and then the medial and lateral tibial plateaus, which are just below the eyes of the joint, and pes anserinus, which is the site of attachment, it is present on the medial side. Then you need to palpate the edges of the medial and lateral femoral condyles. The medial and lateral femoral condyles are palpable, and they become more exposed when the knee is flexed, and they become less exposed when the knee is extended. So it is always advised that you can perform the movement of knee flexion and extension to differentiate between the tibial plateau or the tibial condyles and the femoral condyles as well. And there is also an adductor tubercle which is proximal to the knee joint, and it is on the supromedial aspect of the knee. We discussed this already, that the thickest layering of the cartilage in the body can be found in the posterior surface of the patella. This eighth of an inch thick coating protects the patella from the incredible pressure applied by the quadricep muscles when the knee is flexed. So simply walking up or downstairs can place as much as 600 pounds of pressure on the patella. So this is the reason that it is supplied with a very thick coat of cartilage. In this picture, we are looking at the patella and its mobility. The patella can move in two possible directions: craniocaudal and mediolateral, or right to left direction. And in the normal people, there should be no rub between the patella and the femoral condyles. If you encounter any resistance, or if you encounter any problem or any rub between the patella and the femoral condyles, it shows that there are some osteophytes or there is some degeneration of the cartilage, and that is one of the key features of the patellofemoral pain syndrome, which was previously called as chondromalacia patella. So you need to jump from the patella to the tibial tuberosity. You can resist knee extension to make the patellar tendon, which is a continuation of the quadricep tendon, a bit prominent, and this is the most prominent part when you see from the lateral side. And the shaft of the tibia, it runs all the way down. From the tibial tuberosity, if you move laterally, you will find head of the fibula. So this is a very important clinical site. Then the joint eyes. These are the sites where the knee joint is injected, and this is palpated while the knee is flexed. You can also add a bit of traction, and then you can feel for the joint eyes, and just below the joint eyes you will find the tibial plateaus. Now if you look at this, we are discussing the pes anserinus, which is an attachment site to the sartorius, to the gracilis, to the semicondylous, and all of these they get attached to the pes anserinus, and this is present medially. So this is medial to the tibial tuberosity, and this is pes anserinus, and lateral to the tibial tuberosity is the head of the fibula. The edges of the femoral condyle can be exposed when you try to translate the patella out of your way, and then behind the patella you can find the condyles. The epicondyles, they are a lot spinous like, they have spines and they are a bit rough surfaces, so it is easy to palpate the epicondyles of the femur, and also the adductor tubercle, which is present on the medial aspect, the supromedial aspect of the knee joint. So this is also a very prominent bony landmark. Now if you look at the bones and the bony landmarks of the ankle and the foot, the calcaneus, this is the most prominent and most superficial bone when viewed from the plantar surface. Then the talus can be approached from the tibia. You need to slide down from the tibia and then you can find the talus. The navicular, the cuboid, and the cuneiforms, they are also to some extent are palpable. The metatarsals are palpable very easily, and the phalanges as well. Here you can see how these bones they are connected with each other. The calcaneus, the talus. So there is a joint between talus and calcaneus. There is a joint between tibia and the talus. There is a joint between the calcaneus, talus, and the cuboid and the navicular. And the navicular, it attaches to the cuneiforms, and the cuneiforms also attach to the cuboid on this surface. And then the metatarsals they connect with the cuneiforms and the cuboid. Here you can see the configuration. So this is trochlea, a pulley-like projection of the bone, which is called as the peroneal trochlea. And it is present on the calcaneus and it is present on the lateral aspect. The fifth metatarsal has a tuberosity which is on the lateral surface or lateral side. So this is again very prominent, and the rest of the bones, the middle, lateral cuneiforms, these are, and the medial cuneiform, there are three cuneiforms. So these cuneiforms are present medially, while the cuboid is just proximal to the fifth metatarsal tuberosity and it is on the lateral side. Again, this is a medial view, and in the medial view we can see for all the bones just the navicular tubercle is more prominent, just posterior to the medial cuneiform. So the trail in this region are, you need to find out the lateral malleolus on the lateral side, and it is a projection from the fibula. The medial malleolus, which is a projection from the tibia. Then the calcaneus, which is found posterior to the medial malleolus and inferior to the lateral malleolus. malleolus as well. Then you can find the talus. The talus becomes very exposed when you perform the movement of plantar flexion, and it sinks in when you perform dorsiflexion. So I told you before that the fifth metatarsal, it has a very prominent projection for tuberosity. So this is palpable very easily on the lateral aspect. The big toe has the helix. This is called the first phalanx or the proximal phalanx, and it does not have the middle phalanx. It has proximal and distal phalanx. So proximal phalanx, which is called the helix. Then the first metatarsal behind it. Then you can also see the second, third, fourth, and fifth metatarsal and the phalanges of the fingers. These are present in the midfoot, and if you slide your thumb, palpating thumb from the talus to the inferior surface or towards the big toe, the first bone that you will encounter is the navicular, and it is broad. Then lateral to it or posterior to the fifth metatarsal, you can find the cuboid and then the cuneiforms. The lateral and medial malleolus, they are very easily palpable. The malleolar grooves, they are present on the medial malleolus as well as on the lateral malleolus, and they also act as a pulley through which the tendons they pass. Then the calcaneus, it is palpable, it is distal to the lateral malleolus, and you can find the peroneal trochlea on the calcaneus. You can also find the sustentaculum talli, which is a soft space between the talus and the calcaneus. This is a very interesting fact. Of the 200 different kinds of primates in the world, humans are the only ones with a non-grasping first toe. Since we are no longer tree climbers, our foot has lost its hand-like capabilities in order to become a platform for an upright body. This does not mean, however, that the toes were designed to be inactive. An infant's toe has 20 times the toe grasping capacity of a shoe-wearing adult. So, and in shoeless cultures, people retain the prehensile abilities of their feet throughout their adulthood, using them for swinging and even threading the needles. The talus is a very irregular bone, and it is very similar to a dog's head or dog's face. So you can see it has a head, neck, trochlea, and the lateral tubercle. On the undersurface, it has the tarsal sinus and lateral process. This is a medial view. You can see the head, neck, trochlea, and medial tubercle. So there is a lateral tubercle and there is a medial tubercle. The head of the talus can be palpated if you draw a line from the medial malleolus to the navicular tubercle. In between them, you will find the head of the talus. The hallux, it is the first metatarsophalangeal joint and it is the broadest joint. You can easily find this joint and you can find the prominence in this region. This is the view that shows the muscle mass along the foot's plantar surface, how it is filled between the bones. This is a very important site because this is the site where the plantar fascia is also attached to the calcaneus, and it springs all the way to the metatarsals. And this is also a site for calcaneal spur. It causes a lot of pain, and this is also the site that is approached for the injection purposes. The shaft of the first metatarsal is found just proximal to the hallux and distal to the medial cuneiform. The second through fifth digits, they are very easily palpable. You can find the web space between them, and they are, although they are small bones, but they have the features of long bones, so they are very easily palpable. They have shaft, they have body, and they have the condyles. The tuberosity of the fifth metatarsal, it is present on the lateral aspect and it is very palpable. While strapping on shoes has certainly protected our feet and reduced the number of sprained ankles, it has also wreaked havoc on our arches. With the external support of shoes, our arches no longer need to adapt to varying terrain, and so the normally supportive musculature weakens. Eventually, the arch on the medial side of the foot collapses, resulting in a condition commonly known as flat foot. So, there was a study that described how walking on uneven surface or running on uneven surface can improve your arches and can improve the function of foot. The medial, middle, and the lateral cuneiforms are distal to the navicular and proximal to the metatarsals. So if you jump to the navicular tubercle, then you will find the medial cuneiform. The tuberosity of the fifth metatarsal can be palpated laterally, and it can be helpful landmark. Palpate both structures, the navicular tubercle and the tuberosity of the fifth metatarsal. You need to palpate both and notice how the tuberosity of the fifth metatarsal is further distal than the navicular. So it is a bit distal also. And in alignment with this, you will find the medial, middle, and lateral cuneiform. The cuboid, if you draw a line from the lateral malleolus to the tuberosity of the fifth metatarsal, you will find the bone in between being cuboid. These are the muscles, the gastrocnemius and the soleus underneath the gastrocnemius. The gastrocnemius making the calcaneus tendon, and collectively they are making the tendon Achilles. Why it is called Achilles tendon? Because there was a king known as Achilles, and he used to cut this tendon, the calcaneal tendon, so the prisoners of war, they cannot stand up and they cannot escape. This is an anterior view of the right leg and foot, and you can see the Peroneus longus muscle in the lateral view as well as in the anterior view. This is a very prominent muscle. Then the gastrocnemius on the posterior side. Then the tibialis anterior group of muscle. This is anterior muscle. It contributes in dorsiflexion. Then extensor digitorum longus, which is responsible for extension of the digits. Extensor hallucis longus. This is a single tendon or a single muscle for the big toe extension, and the peroneus tertius tendons, and these reticula are being cut down. This is how the muscles on the front and on the back are arranged. So if you start from the anterior side and the medial side, you will find tibialis anterior to be the most medial. Then lateral to it is the extensor hallucis longus. then extensor digitorum longus, then Peroneus longus and Peroneus brevis. And then there is fibula. And this is the interosseous membrane that is in between the fibula and the tibia. So collectively, these are five muscles that are crossing or that are present on the anterior side. So I'll repeat: the tibialis anterior, extensor hallucis longus, extensor digitorum longus, Peroneus longus and Peroneus brevis. These are the five muscles on the anterior side. And on the posterior side, if you look at the muscles, the flexor hallucis longus, then we have tibialis posterior, similar to tibialis anterior, we have a tibialis posterior. Then we have flexor digitorum longus. This is the flexor digitorum longus. Then we have soleus, which is this muscle. And then we have gastrocnemius continuation, shown here as the calcaneal tendon. This is another view showing you the muscles that we discussed. You can see the tibialis posterior, the flexor digitorum longus, flexor hallucis longus and tibialis posterior over here. These are the muscles that work together for plantar flexion, namely the gastrocnemius and the soleus, and the rest of the muscles they are assisting. For dorsiflexion, tibialis anterior plays the major role, and then the extensor digitorum longus and extensor hallucis longus. For the movement of inversion and eversion, we have tibialis anterior, tibialis posterior, flexor digitorum longus, flexor hallucis longus and extensor hallucis longus. For eversion, we have three muscles: Peroneus longus, Peroneus brevis and extensor digitorum longus. And here you can see how they are passing behind the lateral malleolus. Flexion of second through fifth toes have different muscle: flexor digitorum longus and flexor digitorum brevis. These are contributing. For extension of the second through fifth toes, we have extensor digitorum longus, extensor digitorum brevis, and lumbricals they are also assisting. The gastrocnemius and soleus they make the most of the bulk on the posterior leg. So this is all about the history, why the Achilles, he was a warrior and he cuts the tendons. So you can palpate for the bulk of the gastrocnemius being superficial and the soleus being deep. If you ask your partner to perform heel raises, then the gastrocnemius becomes more prominent. And you can also resist plantar flexion in the knee flex position so as to minimize the stretch because of the hamstring muscles. So then you can perform the resisted movement of plantar flexion and see for the contraction of the gastrocnemius and soleus. So you can see the soleus is present a bit below and the gastrocnemius, its bulk is present superiorly. There is this small muscle called plantaris, and it is starting from the popliteal fossa. It is no mere coincidence that the plantaris of the lobe of the leg bears a marked resemblance to the palmaris longus in the forearm. The two muscles have short bellies followed by long tendons, limited capabilities, and are absent in nearly 10% of the population. The popliteus, also called as the locksmith or the key which unlocks the knee or the locksmith of the knee. Only the tendon of the popliteus can be palpated, and it is present on the lateral aspect. You ask your partner to lie prone, and then with the movement of internal and external rotation you can feel for the tension in the tendon of the popliteus. The Peroneus longus and brevis, they are present on the lateral aspect, and they are palpable with the movements of eversion and dorsiflexion. So these are covering this area between the fibular head and the lateral malleolus. You can resist the movement of eversion to find out for the contraction of the peroneals. So these are the extensors of the ankle and toes, the tibialis anterior, extensor digitorum longus, and extensor hallucis longus. Tibialis anterior being present on the most anterior aspect, and you can resist dorsiflexion to find out the contracting tibialis anterior. Similarly, you can resist the movement of digits extension from second to fifth and feel for the contraction in the extensor digitorum longus. For extensor hallucis longus, you need to resist the movement of extension in the hallux or the first or big toe, and then you can find the tensing tendon and it leads to the muscle. Here you can see the extensor hallucis longus and extensor digitorum longus tendons. The tibialis anterior making the most bulk on the anterior side of the knee, just lateral to the tibial shaft, you will find the tibialis anterior. You can resist the movement of dorsiflexion. For extensor digitorum longus, you can resist the movement of digits or toes extension. This is how you palpate the extensor hallucis longus. The flexors are tibialis posterior, flexor digitorum longus, flexor hallucis longus. So these are present posterior to the tibia. You can resist the movement of plantar flexion to find out the contracting flexors, and you can resist the movement of toes flexion to find out the contraction of the flexors muscles as well. This is how the tibialis posterior passes posterior to the medial malleolus. Collectively, all flexors can be palpated by resisting the movement of plantar flexion. The patient or your partner reciprocally flexes into plantar flexion and then relaxes plantar flexion again. He keeps on repeating, and then you can find the muscles contracting in this region. So it is below or distal to the gastrocnemius and soleus, and it is more anterior to the calcaneal tendon. So Tom, Dick, and Harry is a mnemonic device that corresponds to the initials of the tendons and vessels in the order that they pass by the medial malleolus. Tibialis posterior is the most anterior, you can see over here, followed by the flexor digitorum muscle, the tendon of the flexor digitorum longus, the tibial artery posterior to it, tibial nerve again posterior to it, and the flexor hallux or flexor hallucis being most posterior. These are the muscles of the foot. There are a lot of flexor, the flexor digitorum brevis, abductor digiti minimi, flexor digiti minimi brevis, lumbricals. These are collectively the intrinsic muscles of the foot, and their very small muscles. Here you can see the arches, the medial longitudinal, the lateral longitudinal, and the transverse arch is shown in the foot. Some other small muscles and the retinaculums, they can be seen also. If the discomfort of wearing high-heeled shoes were not enough, try this for size. The point for a spike heel worn by an average-sized woman is subjected to nearly 2,000 pounds of pressure per square inch with every step she takes. This force is shot into the heel and reverberates up the entire body. When air travel was in its infancy, women wearing high heels were actually prohibited from boarding airplanes because the heels of their shoes might pierce the thin metal floors. So it was an interesting fact. Again, these are the small muscles, the extensor digitorum brevis and extensor digitorum brevis. Another view. If you place your fingers just like shown in the picture, you will find the abductor hallucis in this region, flexor digitorum brevis and abductor digiti minimi most laterally. The small muscles, it is difficult to palpate all these muscles because of their size. It is a lot difficult, but you can have an idea where their position is. The small muscles can be felt contracting with resisted movements of toes flexion and extension. So the abductor hallux is for resisting the first or big toe. Then for abductor digiti minimi, you need to resist the movement of abduction of the little finger, and then you can find the contracting muscle. This is the reference for the presentation. Now we will move to the question and answer session if we have any. Thank you very much.